Perfect. Okay. So yeah, we're going to be talking about paediatric jaundice, going through all the key things that you need to know about it via 9 different single best answer questions. And as Keith said, if you have any questions as we go along, pop them in the chat function. I'll try and answer most of them at the end, but if there's any that you really want answering as we go along, then just pop it in the chat, and Keith will sort of highlight some to me as we go along. Okay, so just a little bit about what we're going to cover today. So we're going to start off talking about sort of the general background elements of neonatal jaundice, so definition, a bit of epidemiology, a little bit of a recap on the physiology about bilirubin metabolism, then talking a little bit about the etiology of jaundice and risk factors for it. Then moving on to slightly more clinical things, talking about the presentation of jaundice, how to investigate and evaluate a baby that presents with jaundice. And then finally moving on to talk about management. So covering the key topics like phototherapy, exchange transfusion, and then finishing off talking about key complications of jaundice to be aware of. But we'll start off with a question. Question number 1. A 3-day-old baby born at 39 weeks plus 5 days is seen in GP after parents notice yellowing of her skin. On examination, the GP finds the baby to be clinically jaundiced, but otherwise generally well. Which of the following is correct regarding neonatal jaundice? Is it A, it's generally normal within the first 24 hours of life? B, it's more common in neonates born at term? C, it's generally abnormal within the first 24 hours of life? D, physiological jaundice is often present at birth and persists for the first 4 weeks of life? Or E, physiological jaundice most commonly presents after day 14 of life? So I'll give you a few moments to think about your answer. Okay, let's see what you guys have put. So the vast majority of you have gone for C, with a few of you going for A, a few for D, and a few for E. No one's gone for B. So let's move on to the answer. So yes, most of you are correct. It's C. It's generally abnormal within the first 24 hours of life. And if you remember nothing else about neonatal jaundice, that's the key thing to remember, I'd say. So if we just briefly run through all of the possible answers there. A, generally normal within the first 24 hours of life is obviously incorrect because C is the correct answer. It's generally abnormal. B, more common in neonates born at term. That's incorrect. It's actually more common in preterm neonates. D, physiological jaundice is often present at birth and persists for the first 4 weeks of life. That's obviously incorrect if we're thinking that it's abnormal in the first 24 hours. And it generally resolves within about a week or so, or even less of presenting. So it's not normal for it to persist for 4 weeks. And E, physiological jaundice most commonly presents after day 14 of life. That's incorrect. It generally presents around days 2 to 4 of life. Okay, so moving on, just some basics about jaundice. So obviously it's raised levels of bilirubin in the blood, also known as hyperbilirubinemia, but jaundice is a lot easier to say. There's 3 main types that you can think about sort of chronologically. So the first type is early jaundice. So this is jaundice that appears within the first 24 hours of life. As we've just covered, it's always abnormal. We'll go on to talk a little bit more later on in the presentation about causes of that. Then sort of next chronologically, you've got 24 hours to 14 days of life. This is generally what we call physiological jaundice. So it's usually completely just a normal process. It's not associated with any condition or illness. Although it's worth noting that sometimes abnormal causes of jaundice can present in this time period as well. So you need to make sure that you assess the baby properly before sort of diagnosing physiological jaundice. Again, we'll talk a little bit more about that in detail later on. And then the final type is prolonged jaundice. So this is jaundice that generally appears after or is present more than 14 days after birth, or 21 days if the baby is preterm. This again is most commonly normal. However, it can sometimes be abnormal, so it sometimes warrants further investigation. It can also be helpful to categorise, or you'll hear jaundice categorised into whether it's conjugated or unconjugated bilirubin. Again, we'll talk about this in a bit more detail going forward. Okay, but moving on to question 2. So a 5-day-old baby girl born at 36 weeks gestation is seen at home on a routine midwife visit. The baby was born via planned C-section due to placenta previa and was her mother's first child. She's breastfed and has been feeding well. The baby's mother is generally fit and well, and her father has a past medical history of type 1 diabetes. The midwife advises the baby's parents that she is at higher risk of neonatal jaundice. Aside from prematurity, which of the following features is a risk factor for neonatal jaundice? Is it A, breastfeeding, B, firstborn child, C, female gender, D, delivery via C-section, or E, paternal history of diabetes? I'll just give you a few moments to think of your answers. Oh, there's someone in the chat saying that they haven't got sound. Can most people hear me okay? Great, okay. Well, thanks. Don't know, it might be worth trying to leave and come back in if you can't hear me. Okay. Right, so let's see what everybody's put for that question. So again, most of you have gone for A, with a couple of people going for D. So let's have a little look at the answer. The answer is A, breastfeeding. Most of you had that correct. So yeah, breastfeeding, and particularly exclusive breastfeeding, so when they aren't being fed on anything other than breast milk, is a risk factor for jaundice. The exact mechanism for that is quite poorly understood, but it's an important one to remember for exams. Breastfeeding is related to higher incidence of jaundice, not just incidence of jaundice, but also prolongation of jaundice as well. So babies that are breastfed are more likely to present as jaundice for a longer period of time. Moving quickly through the other potential options. So B, firstborn child, that's incorrect. There's no link between being firstborn and having jaundice. There is sometimes a link between having a sibling that was previously treated with phototherapy. So a sibling that previously required phototherapy, every subsequent child is then at an increased risk of developing jaundice. C, female gender, that's incorrect. So male gender is actually more associated with jaundice than female. D, delivery via C-section, that's incorrect. There's no particular link between C-section deliveries and jaundice, other than, I guess, suppose sometimes if preterm infants are slightly more likely to be born by C-section, thinking of the prematurity factor, but C-section itself, there's no sort of causal link between being delivered via C-section and developing jaundice. And E, paternal history of diabetes mellitus, is incorrect because there's no link between paternal history, but there is a link between maternal history of diabetes and the children developing jaundice. Okay, moving on to the next slide, talking a bit about epidemiology. So jaundice is, particularly physiological jaundice, is very common in neonates. Over half of newborns will at some point develop a small amount of jaundice, and that risk goes up with premature neonates. I think it's something like over 80% of preterm babies can experience jaundice. And as I mentioned, breastfeeding is a particularly strong risk factor for it. So up to 10% of babies that are breastfed exclusively A, experience jaundice, and B, are still jaundice up to 1 month of age. So as I said, breastfeeding increases both the incidence and the duration of jaundice. So it's something really common. It's often normal, but it's important to be aware of the potential abnormal causes. If we talk a bit now about the risk factors, so I've already touched on some of these: prematurity, breastfeeding, previous sibling with jaundice requiring phototherapy, mother with diabetes, male gender, East Asian ethnicities also linked to high rates of jaundice, and living at high altitudes, which I believe is due to the fact that if you're living at a higher altitude, you'll have a higher percentage of red blood cells to adapt for the kind of hypoxic environment in the higher altitude. So more red blood cells will equal more breakdown of red blood cells, which will equal more bilirubin. And okay, of those risk factors, the ones that are most commonly associated with significant jaundice are being premature, being exclusively breastfed, having a previous sibling requiring phototherapy, and also jaundice that has occurred within the first 24 hours of life, which, if you remember, we said is always abnormal, and it's generally associated with more significant levels of hyperbilirubinemia. Okay, so moving on to question 3. A 4-day-old baby boy born at term presents to accident and emergency as his parents noticed a yellowing of the skin around his face and neck. He has been otherwise generally well with no complications during pregnancy or birth. After examination, a blood serum sample is taken to investigate. The findings of this test were suggestive of mild physiological jaundice, and the baby was discharged to home. Which of the following substances is raised in physiological jaundice? Is it A, urobilinogen, B, stercobilin, C, urobilin, D, conjugated bilirubin, or E, unconjugated bilirubin? So I'll give you a few moments to think of your answers. And just whilst you're thinking of that, I've just seen a question: why does breastfeeding increase the risk of jaundice? As I mentioned, the exact mechanism behind it isn't particularly clear. There are a few theories, but there's no definite sort of causal link found there. It's just known that it is associated with breastfeeding. So sorry, that's not a fantastic answer to your question, but still up for debate, really. Okay, let's see what you all went with. So everybody answered either D or E, which is good. Most of you went with E, with a few of you going for D. So the answer is E. It's unconjugated bilirubin. All these terms I will go on to talk about on the next slide. And hopefully it will all become a bit clearer. So this slide is just a kind of recap of bilirubin metabolism, because it's really helpful to have this in mind when you're thinking about the causes of jaundice in particular. So if we just go through this, you've obviously start off with red blood cells. Red blood cells last for about 120 days. Before they eventually get broken down, mainly by macrophages in the spleen, although it does happen in other parts of the body as well. I won't go into the detail of it, but essentially through a series of kind of oxidative reactions, the heme part of hemoglobin is broken down into bilirubin, and then bilirubin enters the bloodstream. It's initially called unconjugated bilirubin. Unconjugated bilirubin, important thing to remember about it is that it's lipophilic, so it's lipid soluble, which means that it can cross plasma membranes more easily, which is why in the bloodstream it's bound to albumin to keep it there in the bloodstream and to stop it from passing out of the blood vessels. So unconjugated bilirubin lipid soluble, bound to albumin in the bloodstream. When the bilirubin reaches the liver, it passes into the hepatocytes and is kind of passed over from albumin to this other protein called ligandin. So ligandin kind of takes over control of the bilirubin, helps transport it into the hepatocytes. And in the hepatocytes in the liver, that's where this important reaction called conjugation occurs. So bilirubin is conjugated to a glucuronic acid molecule via an enzyme called glucuronol transferase. And after that, it becomes conjugated bilirubin. Conjugated bilirubin, importantly, is not lipid soluble, it's water soluble. This is a really important aspect, and the reason why we're interested in the difference, or one of the reasons why we're interested in the difference between unconjugated and conjugated bilirubin. So again, if you remember only a few facts from this lecture, that'll be one of the ones to remember. So conjugated bilirubin, once it's been made in the liver, because it's now water soluble, it's now kind of put into the biliary system and excreted via the bile into the gut, into the small intestine. The conjugated bilirubin in the gut is then further metabolized by bacterial proteases in the gut to something called urobilinogen. Urobilinogen then either undergoes one of three different types of metabolism. So it either goes back into the bloodstream and then ends up back into the liver. Some of it in the bloodstream, instead of going to the liver, goes to the kidneys, where it becomes urobilin. Urobilin is then excreted in the urine, and it's what partially gives urine that yellow colour. And some of it doesn't end up in the bloodstream, it stays in the bowel and is secreted in the feces. And it's turned into, before this happens, something called stercobilin. And stercobilin is what causes a kind of brownish tinge to feces. So when you bear that in mind, it helps you appreciate why people who have cholestatic or like obstructive causes of jaundice, so where there's an issue with the movement of bilirubin via the biliary system down into the gut, that's why you get pale stools and dark urine, because you get less conjugated bilirubin that's turned into urobilinogen and ultimately then stercobilin. So you get those pale stools because there's less stercobilin there in the stools. And because you kind of get like a backflow of conjugated bilirubin, it ends up in the bloodstream and ends up being excreted via the urine, and that makes the urine dark. So that's where you get that pale stool, dark urine from. Okay, moving on to the next slide. So there are kind of two key reasons why physiological jaundice happens, if we bear in mind the kind of metabolism of bilirubin. The first key reason is that there are more, or thinking about red blood cells, in the fetus. The fetus has fetal erythrocytes. After birth, they get replaced by normal erythrocytes. Fetal erythrocytes are more that you have more of them than a baby will when they get rid of their fetal erythrocytes. So you're getting rid of those extra fetal erythrocytes, and also fetal erythrocytes have a higher turnover. So you've got more of these blood cells to get rid of, and they have a higher turnover after you're born. The second key reason is because of the neonate's liver. So in the womb, the fetus doesn't do a lot of its own bilirubin metabolism. A lot of the bilirubin that is created in the fetus's circulating volume gets dealt with by the placenta. So it doesn't have to have high stores of ligandin and the enzyme glucuronol transferase in order to kind of get rid of its own bilirubin and metabolize its own bilirubin. So initially after birth, there's a period of time where the baby's kind of building up its stores of ligandin and glucuronidyltransferase, and it kind of becomes a little bit overwhelmed with the amount of extra bilirubin that's being created by the turnover of these red blood cells. So that's why initially you get you've got excess product and the production line's a bit slower, so you end up with a backlog, and that's when the babies can become jaundiced. Okay, moving on to question number 4. A newborn baby boy born at 38 weeks gestation receives a newborn assessment in hospital 8 hours after birth. It's noted during this check that the baby is jaundiced and is quite lethargic, and hepatosplenomegaly is found on examination of the abdomen. His mother was in the country visiting family when she gave birth and did not receive antenatal care for this or her previous pregnancy in the UK. The baby's blood group is currently unknown, but the mother's blood group is known to be AB rhesus negative, and the father's blood group is known to be O rhesus positive. Which of the following causes of neonatal jaundice is it important to urgently investigate in this patient? Is it A, hemolytic disease of the newborn, ABO incompatibility, B, hemolytic disease of the newborn, rhesus incompatibility, C, physiological jaundice, D, Gilbert's syndrome, or E, breast milk jaundice? I'll give you a few moments to think of your answers. Okay, let's see what you put. So split between A and B, vast majority, 90% if you went for B, with a few of you going for A. So let's see what the answer is. The answer is B. So most of you were spot on. If we go briefly through each of them, so hemolytic disease of the newborn, that's a key thing to be aware of when you're thinking about jaundice in the first 24 hours. Whether it's ABO incompatibility or rhesus incompatibility, you can kind of deduce based on the history here. So the mother is, her blood group is AB, so she's not going to have develop antibodies to A or B, therefore it's really unlikely to be ABO incompatibility. She is, however, rhesus negative, and the father is rhesus positive. We don't know the baby's blood group, but there's a possibility that the baby could also be rhesus positive. Given that the mum didn't receive her antenatal care in the UK, she might have not received anti-D. So there's a possibility that hemolytic disease of the newborn with rhesus incompatibility could be going on here. Option C, physiological jaundice. Obviously, it's not going to be physiological if it's within the first 24 hours of life, and it's not really something that we need to urgently investigate. D, Gilbert's syndrome. We'll go on to talk about that a few slides' time. And E, breast milk jaundice. Again, as I said, it's essentially not uncommon, and it's not something that we need to urgently investigate. It's quite common that breast milk feeding is associated with jaundice. So we're going to talk now about the causes of jaundice and kind of split it into those 3 time categories. So whether it's first 24 hours, 24 to 14 days, or beyond 14 days. So causes of jaundice within the first 24 hours, as we mentioned, this is going to be abnormal causes of jaundice. So the most common cause would be some form of hemolysis. As we already mentioned in the previous slide, when we're thinking about hemolysis, you want to be thinking of hemolytic disease of the newborn. That's something you have to rule out in a baby with jaundice that presents within the first 24 hours of life. More commonly, it will be rhesus incompatibility rather than ABO incompatibility. However, because of anti-D treatment that we give as part of our antenatal care in the UK, we've massively decreased the rates of rhesus incompatibility. So actually we probably see ABO incompatibility more, if that makes sense, but not because it occurs naturally more commonly, but just because we're better at treating or preventing rhesus incompatibility. So just a very brief recap of what happens there. Essentially you get rhesus anti-D isoimmunization of the mother, which occurs whilst the baby is in the womb, which leads to transplacental transfer of IgG antibodies and then eventually fetal hemolysis. But as I said, we treat this in the UK as part of our antenatal care. We'll check a mother's blood group, and if a mother is rhesus negative, we will treat her with anti-D at certain points during her pregnancy to prevent this isoimmunization occurring. Presence of a hematoma might also be another cause for increased hemolysis after birth. Other causes aside from hemolysis could be sepsis. So you want to think about infections within the first 24 hours of life. Particularly you're thinking about congenital infections, so you're thinking of your torch screen, or potentially sort of an early postnatal infection. And then you've got some more rare causes. So glucose 6-phosphate dehydrogenase, or G6PD deficiency. G6PD is an enzyme that's involved in protecting red blood cells from oxidative stress. So if you're deficient in it, you will have an increased risk of oxidative stress and therefore hemolysis on your red blood cells. Hereditary spherocytosis. This is a condition, a genetic condition where you have a defect in the genes that encode for proteins involved in the membrane and therefore the structure of red blood cells. So in hereditary spherocytosis, you get these abnormal shaped, sphere-shaped red blood cells, which are called spherocytes, and those spherocytes are at higher risk of rupturing, and therefore you can end up with hemolysis, increased rates of hemolysis. And Gilbert's syndrome, this is a mostly autosomal recessive condition where you have a deficiency of an enzyme that's involved in the conjugation of bilirubin. So if you remember back to that slide a few slides ago, the conjugation that occurs within the liver. So that essentially decreases, slows down the metabolism, and you can get a build-up, a backlog, if you like, of bilirubin. And that's generally precipitated by stress, illness, or dehydration. I went to school with somebody that had Gilbert's syndrome, and every time, like summertime when it came to exams, you just noticed the sclera of his eyes start to go yellow because he got more and more stressed. That's really weird. Okay, so moving on now to our next kind of time category. If you have a baby that presents with jaundice between 24 hours and 14 days of life. So this, by far and away, is most commonly just normal physiological jaundice, nothing to worry about. However, it's worth remembering that abnormal causes of jaundice can still present in this time period, so it's not always normal. You need to look at the baby as a whole and look at the clinical picture. You also want to look for signs of dehydration and inquire about feeding regimes and how well the baby's feeding, because dehydration can increase the sort of serum concentration of the bilirubin. And even if it's physiological jaundice, in a dehydrated baby, it can become more serious. So even if it's physiological jaundice, you still need to assess the baby and make sure that they're not at risk of dehydration. And then moving on to our next time period. So jaundice that is still present beyond 14 days of life, which is what we call prolonged jaundice. It's helpful to break this down into conjugated, unconjugated, or mixed levels of hyperbilirubinemia. So if you've got conjugated hyperbilirubinemia post 14 days, it's most likely to be physiological, and sometimes if it's associated with breastfeeding, it's called breast milk jaundice. If you've got a mixed picture, it could be sepsis or infection. If you find high levels of conjugated bilirubin, that conjugated hyperbilirubinemia is always abnormal. It's always caused by something unusual going on. It's never physiological. And you can kind of break it down into certain sort of groups of things that might be causing that. So endocrine causes, you've got hypothyroidism, hypopituitarism, gastrointestinal causes, things like biliary atresia, choledochal cysts, which are like an abnormal shaped common bile duct. It's a congenital malformation, or neonatal hepatitis. Essentially all the causes of conjugated jaundice are linked to a kind of cholestatic picture where there's some reason why it's like there's an obstruction going on and the bile flow isn't happening. So that's why biliary atresia, choledochal cyst, hepatitis, so the liver's not able to kind of undergo the metabolism, as well as a kind of stasis that occurs in the liver because of the kind of swelling that happens with hepatitis. Parenteral nutrition, this is well known to be linked to cholestasis. The cause of that is kind of unclear, and the only way to reverse it is to just stop parenteral nutrition. Cystic fibrosis can rarely be associated with jaundice as well. They think that that's probably because you get, because of the cystic fibrosis, you get bile that's sort of thicker and increased in density, and that slows down the movement of bile through the common bile duct and can cause bile stasis. Galactosemia and other amino acidureas are also rarer causes. Galactosemia would only present after the baby started having lactose in its diet. Okay, moving on to the presentation. So jaundice initially presents in the face and the forehead. It's generally easier to see if you try and blanch the skin, and you'll see it yellowing more clearly that way. It then spreads as levels of bilirubin rise. It spreads down the trunk and into the extremities, which is something that's called a cephalocordial progression. It's a fancy way of just saying like the head to the extremities, and it generally then resolves in the opposite order. So as bilirubin levels are going down, the jaundice kind of goes back, and the last place it will be seen is in the face and the forehead. In a baby with physiological jaundice, the yellowing colour of the skin may be the only thing that you find. Otherwise, the baby may be completely fit and well. However, it's important to be aware of other potential things that they might present with. So high levels of hyperbilirubinemia can be associated with drowsiness. You want to be looking out for certain neurological signs which might indicate an acute bilirubin encephalopathy, which is something that we'll talk about near the end of the presentation. But these kind of signs are things like abnormal, like muscle tone, hypertonic or hypotonic, seizures, altered crying. They might present with pale stools and dark urine. If you remember what we said in the bilirubin metabolism slide, if you've got kind of cholestasis, you can end up with decreased levels of stercobilin and conjugated bilirubin going into the urine. So that's related to conjugated hyperbilirubinemia. And then things like splenomegaly, petechiae, they might also be present in conjugated hyperbilirubinemia, particularly if there's an issue going on with the liver, and they might also develop hemolytic anemias. Right, okay. So moving on to question 5. A 4-day-old baby girl born at 39 weeks is seen at home by a midwife. Parents are concerned regarding a yellowish colouring of her skin, which developed that morning. The baby has otherwise been completely well. The midwife has a transcutaneous bilirubinometer with her and suspects that the baby is jaundice. Which of the following would be the next most appropriate action for the midwife? Is it A, no further action is needed as the baby is well? B, return to reassess tomorrow and measure transcutaneous bilirubin levels if the baby becomes unwell? C, refer to hospital for assessment and measurement of serum bilirubin? D, measure transcutaneous bilirubin levels with a bilirubinometer at home and check serum bilirubin if the bilirubin level is above 250 micromoles. Or E, refer to hospital for observation and assess serum bilirubin. Jaundice appears to worsen. So I'll give you a few moments to think of your answers. I'm just having a few look at the questions as well. Somebody said, why do you get jaundice with sepsis? That's a good question. I think a multitude of factors. Could be increased breakdown of red blood cells due to the infection, could be decreased circulating volume, which can then kind of increase the concentration of bilirubin in the blood. And does hemolytic anemia have high unconjugated or conjugated bilirubin, and why? Well, if you think about our bilirubin metabolism slide again, in hemolytic anemia, you're getting an increased level of broken down red blood cells, therefore an increased level of the unconjugated bilirubin. So you essentially get higher levels of unconjugated bilirubin occurring in the blood because of the hemolysis that occurs. Okay, I hope that answers your questions. Okay, right, sorry, let's move back on to question 5. So let's see what most of you went for. Oh, quite split. Most of you went for D, but a few of you opted for each answer. So let's see what the answer is. Most of you were correct, it's D. So I'll go on to talk about each point and kind of address each point in the following slides. Essentially, well, I'll move on to the next slide and all will become clear. But yes, the correct answer was measure the transcutaneous bilirubin levels and check the serum levels if the bilirubin level is above 250. So, investigation of jaundice. So you measure bilirubin, and it's important really here to say you measure serum bilirubin. If the jaundice occurs in the first 24 hours of life, so you'd never check, you'd always want to see what the bilirubin level is if jaundice occurs in the first 24 hours of life, and you'd never check it via a transcutaneous bilirubinometer. The infant is jaundiced and also unwell, you'd always want to check serum bilirubin, or if the jaundice is prolonged, particularly because you'd want to be looking at whether it's conjugated or unconjugated bilirubin. Measurement of bilirubin can be done by serum or transcutaneous. Transcutaneous measurements can be used if the baby is more than over 35 weeks gestation and outside of 24 hours, the first 24 hours of life. Serum levels can be measured, it can be used if transcutaneous is not available, or if the baby is less than 35 weeks gestation within the first 24 hours of life, or if the transcutaneous result is above 250. In actual practice, transcutaneous bilirubin, I've never seen it measured actually in hospital. That's probably more comes into play when you're thinking about community, like midwives and community treatment of babies. But in hospital, what you'll see on your placements is always going to be serum, almost always, I would say. But it's still important to be aware of the existence of transcutaneous bilirubin monitoring and when it can and can't be used. Okay, moving on to the next slide. So this graph is something that if you do a paediatric placement, you will become well acquainted with. So NICE have produced several graphs that look quite similar to this. They help you decide whether the serum bilirubin level is above the threshold for treatment, A with phototherapy and B with exchange transfusion, based on how many days of life the baby is. It's really important to remember that these graphs vary depending on what the week's gestation is. So you have to make sure that you've got the right weeks gestation graph before you try and interpret it. And also remember that you're looking at the total serum bilirubin level rather than like the split. So don't look at measure the unconjugated level, say it's the total serum bilirubin level. Okay, so moving on to the next question. A 5-day-old baby boy born at 40 weeks gestation presents to A&E with poor feeding and lethargy. His mother reports that she has been exclusively breastfeeding and is keen to continue. On examination, it's noted that the infant appears jaundiced and has slightly dry mucous membranes. Otherwise, all findings are normal. The hospital does not have a bilirubinometer, so serum total bilirubin levels are measured, which are found to be 305 micromoles. Using the treatment threshold graph, which of the following is the next best course of action regarding management of this baby's jaundice? Is it A, send them home, no need to check bilirubin levels? B, send home and recheck bilirubin in 24 hours? C, recheck serum bilirubin within 18 hours and keep in hospital during that time? D, commence phototherapy? Or E, commence exchange transfusion? So I'll give you a few moments to have a little look at that graph and see what you think the answer is. And I'll just have a little look at the questions in the meantime. Somebody said, when do you give IVIG? Is it after you've exhausted exchange phototherapy and exchange transfusion? We'll come to that at the end of the presentation. I've got a brief slide on it, so all will be revealed. Okay, let's see what you put. Ooh, quite a split one again. So B narrowly has it with 37% of you, closely followed by C, then D, and then kind of a few of you went for A and E. Let's see what the answer is. So the answer is actually C. Recheck serum bilirubin within 18 hours and keep in hospital during that time. That was a tricky one. I can see why most of you are split between B and C. I'll go on in the next slide essentially to explain why the answer is C. But obviously you can tell from looking at the chart, if you use it correctly, that the answer's not D or E, because if we look at it's 5 days old and we go along to, what was it, 305, you can see that we're sort of not above the blue or the red lines for 5 days. So it's not going to meet the treatment threshold for either of those treatments. But it's just about whether or not you send them home, recheck them, and when do you recheck it. So, when not to treat hyperbilirubinemia? Well, essentially, if you check the bilirubin and it's within 50 millimoles below the threshold for either treatment, but particularly when we're thinking about phototherapy, essentially you need to recheck again to make sure, because it's so close to the treatment threshold line, that it's not going to eventually end up going over it. And the timing of that depends on whether or not there are risk factors for neonatal jaundice or not. So if we go back to our previous question, the baby was breastfed, so that baby has a risk factor for neonatal jaundice. Therefore, you would want to recheck the bilirubin within 18 hours. If that baby hadn't had any risk factors, then the answer would have been recheck it within 24 hours. If you have a baby and they're jaundiced, you check the bilirubin and it's more than 50 below the threshold for that gestation and that many days of life, then you don't need to recheck it. So it's only if it's within 50 millimoles that you micromoles that you need to recheck it. Okay, so investigation, other things other than just checking the bilirubin that you would do for a baby that presented as jaundice within the first 24 hours of life. So you're always going to obviously check the serum bilirubin. You would never try and check it transcutaneously, and you want to check it within 24 hours of the jaundice developing, ideally. It's basically ASAP. Other bloods that you might do, FBC, a blood film, looking for evidence of hemolysis and looking for, I suppose, other things like abnormal blood cells, spherocytes, that kind of thing. You do a direct antiglobulin test or a DAT test, also known as the Coombs test. That tests for IgG antibodies, which have been passed via the placenta from the mother who has undergone rhesus anti-D isoimmunization. So essentially you're testing for hemolytic disease of the newborn. It's worth noting that ABO incompatibility is often DAT negative, and that's because there's less severe hemolysis that occurs compared to rhesus disease. And it's also worth noting that occasionally, if a mother has been treated with anti-D during her pregnancy, a baby may still have a mildly positive Coombs test or a DAT test, even if there's no hemolytic disease of the newborn occurring. You might also do cord bloods. It's sometimes not possible by the point at which the jaundice occurs. You kind of send them paired, so you'd send the same tests as you would do as you're doing from the fetus's blood. Sometimes cord bloods can be beneficial because they can kind of give you an idea of how the picture is developing, if that makes sense. So cord bloods kind of show you at the point of birth, and then if you're testing the bloods a bit later on, it can kind of show you the levels of like how the bilirubin has changed and things like that, but they're not always sent. Infection. So obviously you want to be ruling out infection. So we mentioned sort of doing a general septic screen, a torch screen, looking for things like toxoplasmosis, etc. And if the baby is from the Far East or the Middle East or African, you might want to consider a G6PD deficiency test, but we're kind of reaching into the more rare causes there. You definitely want to exclude hemolytic disease and infection first. Okay. So now moving on to jaundice that occurs between 24 hours and 14 days. So generally you'd want to, if you're going to check the serum bilirubin, you want to check it within about 6 hours. Other bloods that you might do would be similar to what you would do with jaundice in the first 24 hours if you're worried about infection, FBC, blood film, Coombs test. You might also want to check LFTs to check for anything like hepatitis or a kind of cholestatic picture. TFTs to look for potential endocrine cause. As I said, septic screen, and also consider the rarer causes as well. But obviously you're going to want to be ruling out anything more common first. You might also consider, if you find any abnormalities, particularly in the LFTs, consider doing something like a liver ultrasound or biopsy. But again, that's not really part of initial routine testing. It's just something to keep in the back of your mind. And then investigating prolonged causes of prolonged jaundice. So the baby's presenting with jaundice beyond 14 days of life. If it hasn't been done already, you're going to want to make sure you get a split bilirubin level to see whether there is raised levels of conjugated bilirubin. As we've mentioned before, that might indicate one of the previously mentioned causes, something endocrine, metabolic, or GI cause. And then again, most of the tests as before to look for the other causes, although obviously something like hemolytic disease of the newborn is much less likely to present after 14 days. And then some other things you might want to think about, things like sweat tests for cystic fibrosis, alpha-1 antitrypsin phenotype, or kind of some of the more weird and wonderful causes, so looking into the amino acid ureas. Okay. And yes, it's worth just reiterating that any elevated conjugated bilirubin is going to be abnormal, and therefore most babies where you find that will be kind of referred on to specialist services, probably a paediatric gastroenterologist. Okay, question 7. A 2-day-old baby girl born at 38 weeks.
Caitlin, sorry to interrupt. There's just a few questions relating specifically to the previous SBA, so I was wondering if it would be worth answering them now or holding it till the end.
Yeah, let's have a little look at them now, shall we? So somebody's put in the chat, would you check it if they had risk factors but were over 50 millimoles from the threshold? No, it's only if they're within the 50 millimoles from the threshold that you need to recheck. I suppose you would probably look at the clinical picture and it would be a consultant's decision. I wouldn't say that it would never happen, but according to the guidelines, you wouldn't be expected to. Although you have to look at the baby as a whole, the baby's presentation, how worried you are about them clinically, and take that into account. And then just have a little look. Is another risk factor that the baby was slightly dehydrated? Does dehydration affect the answer? Let me just go back to that question. I suppose why did I put that the baby was dehydrated? I suppose I was just thinking, sometimes I was just trying to give more of a realistic clinical picture. I think babies that are exclusively breastfed can sometimes be slightly more dehydrated than babies that are formula fed initially if there's issues with breastfeeding, struggling with breastfeeding and with breast milk production. And I suppose that would make you potentially more worried about the baby and thinking in terms of, that's probably why you keep them in hospital in particular during that time. But it's not specifically a risk factor for, yeah, I suppose it is a risk factor as well. I suppose that is also related. I don't know whether it would mean that you would check it more regularly than within 18 hours, but you probably keep a closer eye on the baby in general. And why does hypothyroidism cause high conjugated bilirubin? The exact answer to that I'm not sure of. I think it's because there is a link between hypothyroidism and a kind of cholestatic picture. But I'll be honest, I don't know the exact science behind it. And when I tried to find out, I didn't really get much answers. So I would suspect that there's possibly not a very clear answer as to what the mechanism is behind that. And I think that's all the questions there. So let's go back to the next question. Question number 7. A 2-day-old baby girl born at 38 weeks plus 2 days gestation is referred to A&E by a midwife following a transcutaneous bilirubin level of 325 micromoles. On investigation, serum bilirubin is found to be 330. The baby is otherwise generally well. Using the treatment threshold graph, which of the following is the next best step regarding the management of this baby's hyperbilirubinemia? Is it A, commence exchange transfusion, B, commence intensified phototherapy, C, send home and recheck the bilirubin within 24 hours in the community, D, commence phototherapy and recheck serum bilirubin in 12 hours, or E, commence phototherapy and recheck serum bilirubin in 4 to 6 hours. So I'll give you a few moments to think of your answer. Okay, so we're a bit sort of running over on time. Let's move on. Let's see what you all put. Most of you went for D, with a few of you going for E, A and B as well. Let's see what the answer is. So the answer is E. Just to kind of briefly touch on them. So if you look at the graph, you can tell because they are, you want to check obviously it's the right gestation, which it is. It's 38 over 38 weeks gestation. If you look at day 2 of life, look at 330, you're kind of in between, you're above the phototherapy line but below the exchange transfusion line, so you're going to want to give them phototherapy. I'll explain the difference between phototherapy and intensified phototherapy in a few slides time, but essentially that's why you would commence phototherapy, and then it's just based on sort of timing, isn't it, of when you recheck the serum bilirubin, which I will address in the next few slides. Okay, so going on to talk about the management of jaundice, so starting off talking about phototherapy. I suppose there's 2 main ways of treating jaundice, which is phototherapy and exchange transfusion, and we'll talk about them both in the coming slides. So phototherapy, I don't know if any of you have seen it on your placements, but it's basically using blue or green lights on the baby, like directed at the baby. And essentially why that helps, why that treats the jaundice, is because of a chemical reaction that occurs when bilirubin is exposed to the blue and green lights. So bilirubin gets converted via a sort of photochemical reaction into 2 things. One is called photobilirubin and the other is called lumirubin, and they're both excreted via the liver and the kidneys. An important thing to think about in terms of these 2 products, so the photobilirubin and the lumirubin. Most bilirubin on exposure to light is converted into photobilirubin. However, that reaction is reversible and photobilirubin is quite slow to be excreted, which is why when you take the lights off, you can get something called rebound jaundice, because some of that photobilirubin will get pushed back into becoming bilirubin and reverse back along that pathway. So that's why you need to be wary of rebound jaundice. Lumirubin, although there's much less of it created than photobilirubin, that's irreversible and it's excreted much quicker. So it's likely that the conversion of bilirubin to lumirubin is actually responsible for most of the kind of effects that you get from phototherapy. So the lights are generally placed about 15 to 30 centimeters away. The general principles, you want to maximize exposure of the baby's skin surface to the lights, and you also want to make sure that you maximize the time that the baby has under the lights. You can sometimes find, if you're rechecking serum bilirubin and you're like, why isn't this bilirubin going down? It's because mum keeps taking the baby out from under the lights to have a cuddle, which is totally understandable, but you have to try and encourage them to keep the baby under there for as much as possible, but also taking into account that it's important to have bonding between the mother and the baby, breaks for breastfeeding, nappy changes, and you also want to make sure that the baby's eyes are covered by a little eye guard to stop damage to the retina from the lights. Yes, so that's the kind of key things to think about with phototherapy. It's also important to think about the fact that because that baby is exposed to a light, they're at higher risk of dehydration, and we already know dehydration plus jaundice is not good. So it's important to make sure that you're assessing the level of hydration of the baby whilst they're under the lights. Okay, and then going on to talk about intensified phototherapy. So this is essentially, you might hear it get termed as like double light. So it's when you go from just using 1 light to using 2 lights, and it just increases the intensity of the light on the baby. You might also hear something called a billy blanket. There's a picture of it, a slightly blurry picture of it on this slide. It's not routinely used in the UK, but you might come across it. It's kind of like a little blanket that wraps around the baby, and the idea is that it kind of increases the surface area exposure to the lights, but they're not as strong as the lights, so that's why they're probably quite expensive, which is why they're not as commonly used in the UK. But it's helpful to be aware that they do exist. They'd never be given as monotherapy alone, they'd always be given in conjunction with the lights as well. Indications for intensified phototherapy include if you've got bilirubin that's rising quickly, so more than 8.5 micromoles an hour, or if it's within 50 millimoles of the threshold for exchange transfusion, you probably go in straight away with intensified phototherapy. Or if you find that the levels are static or rising after they've been on phototherapy for quite a long time, you might consider going to intensified phototherapy as well. In intensified phototherapy, you want to try and minimize the amount of time the baby's spending under the lights, because there's a reason why they're on the intensified phototherapy. So you might suggest that feeds are given via formula or express milk rather than breastfeeding directly, so that the baby just stays under the lights for as long as possible. Okay, question number 8. A 5-day-old male baby was commenced on phototherapy treatment for hyperbilirubinemia. After 14 hours of treatment, serum bilirubin levels fall to 285 micromoles per litre. Treatment threshold for phototherapy in this group is 350. Which of the following is the most appropriate course of action regarding management of this baby's jaundice? Is it A, stop phototherapy and recheck bilirubin levels at 12 to 18 hours time, and bilirubin if the bilirubin remains over 50 micromoles below the treatment threshold, no further monitoring is needed. B, stop phototherapy and discharge to home. C, continue phototherapy until bilirubin is at least 100 below the phototherapy treatment threshold. D, commence intensified phototherapy until bilirubin is at least 100 below the phototherapy treatment threshold. Or E, stop phototherapy and recheck bilirubin levels in 12 to 18 hours time. Continue to recheck until levels are over 100 below the treatment line. So it's quite wordy, that question, so I'll give you a few moments to think of your answers. Okay, let's see what you put. Ooh, split. Most of you went with A, a few of you with E, and then a few less of you with C. No one went for B or D. Right, let's see what the answer is. The answer is A. So you stop phototherapy and recheck bilirubin levels in 12 to 18 hours time. And if the bilirubin remains over 50 micromoles below the treatment threshold at this time, no further monitoring is needed. So I'll go on to talk about the management in the next slide. So serum bilirubin monitoring. So essentially, once the baby's on phototherapy, you're going to want to be continuously rechecking the bilirubin. It's just how often do you do that? After initially initiating it, you want to recheck it within 4 to 6 hours. That will probably depend upon how worried the consultant is about the baby. Generally, I mostly saw it rechecked at 6 hours, but I'm sure if the consultant was really worried, you might recheck it in 4. And then after that initial recheck, you would continue to repeat every 6 to 12 hours once the level is kind of stable or starting to fall. Again, I usually saw it checked about 8 hours, but it would depend on how worried the consultant is about the baby. If the bilirubin levels are not responding to phototherapy, then you want to check a split level as conjugated bilirubin doesn't always respond in the same way to phototherapy as unconjugated does. It's also worth noting that if you've got a conjugated hyperbilirubinemia and then you give phototherapy, you can end up with something called bronze baby syndrome, which is conjugated, basically how conjugated bilirubin sort of reacts to the phototherapy. It can cause this like bronze discoloration of the skin. I'm not sure exactly why, but that might be an indication if you see that the baby has got a conjugated hyperbilirubinemia. Other considerations whilst the baby's under phototherapy, we mentioned make sure you're checking their temperature and their level of hydration. Temperature could go up, hydration, they could become more dehydrated, so you want to be on guard for that. And eye care, if they're under those lights and they've got that shield on for a long period of time, you want to make sure that they have good eye care underneath there. And if you can have some periods when they have the eye shield off, and they can help with their sort of visual development to be able to actually see for short periods of time at least. Okay, and when to stop phototherapy. So you've had your baby with jaundice, you've started phototherapy, you've been rechecking serum bilirubin, and at what point do you stop? Essentially, it's when the levels have fallen to at least 50 below the treatment threshold line. So you don't stop as soon as it goes under, you wait until it's over 50. And then if you remember, we talked about why you can develop rebound hyperbilirubinemia. So you want to, once you stop the phototherapy, you have to recheck the bilirubin around 12 to 18 hours after stopping to make sure that the baby doesn't develop rebound hyperbilirubinemia. If at that point, after when you've rechecked it after stopping phototherapy, the bilirubin is still more than 50 below the threshold, then you don't need to keep monitoring, and you can send the baby home if that's all that was keeping them in hospital. If it's within 50 millimoles of the treatment threshold, then you would repeat again or consider restarting phototherapy based on how worried you are about the baby, what the risk factors are, and the sort of general clinical picture. Essentially, when they're more than 50 below the treatment threshold, you stop, check again in 12 to 18 hours. If it's still more than 50 below, then you're fine. If it's gone back up to within 50 or above the treatment threshold, you would either restart phototherapy or consider repeating it again. Okay, so now talking about exchange transfusion. So this is essentially the process of slowly removing and replacing the circulating volume of the baby's blood in order to reduce whatever circulating toxin is present. In this case, obviously, we're talking about bilirubin. It started if the bilirubin levels are above the exchange transfusion threshold, or if the baby starts to develop clinical signs indicative of acute bilirubin encephalopathy. So if you're concerned about that, if the baby started developing neurological signs, you would skip phototherapy or stop phototherapy at that point and consider starting exchange transfusion. The amount of blood that is replaced is generally calculated based on estimating the baby's circulating volume. So I think generally for term babies, it's 80 mils per kilogram, and for preterm infants, it's 100 mils per kilogram. And then once you've estimated the circulating volume, you'll aim to give twice the circulating volume in total. And if you do that, you'll generally have achieved replacing roughly 85% of the blood volume overall, and ideally reduce bilirubin levels by about 50%. And after exchange transfusion is completed, you will recheck the bilirubin levels 2 hours afterwards, and then you just go again based on the treatment where the bilirubin is in the treatment threshold, whether you need to repeat it or go down to phototherapy. And you also continue phototherapy during and after, whilst you're waiting to repeat those levels. Now moving on to IgG, the that whoever it was asked that question, patiently awaiting this answer. It's probably not very exciting. Essentially, it can be used in cases of rhesus or ABO hemolytic disease where the serum bilirubin rises above 8.5%, so basically where the serum bilirubin is rising rapidly. And then let me just reread your question to make sure I've properly answered. When do you give IgG? Is it after you've exhausted phototherapy and exchange transfusion? So essentially, you'd only give it if it's hemolytic disease, and you would only give it in hemolytic disease where the bilirubin levels are rising rapidly, essentially. So you might give it whilst the baby's receiving phototherapy or whilst they're having an exchange transfusion. You probably wait until after if you were going to do an exchange transfusion, but it's more based on the rapidness of the rise rather than where the bilirubin level falls on the treatment graph, if that makes sense. I hope that's answered your question. Okay, and then other additional management kind of obviously depends on the cause of the jaundice. In physiological jaundice, the most common cause of neonatal jaundice, generally treatment wouldn't be likely to extend beyond phototherapy. It's very, very, very unusual if you had to give an exchange transfusion for physiological jaundice. Okay, moving on to the last question. Sorry, I realised that I've really overrun, so I'll try and speed through. A 5-hour-old neonate born at 36 weeks gestation is found to have significant hyperbilirubinemia. During assessment, it's noted to have increased lethargy and found to be hypertonic on examination. The medical team is concerned that the infant has developed an acute bilirubin encephalopathy. Which of the following statements is correct regarding ABE? Is it A, that treatment is not required unless seizures develop? B, it's less common in neonates than adults? C, it's irreversible? D, it's caused by a toxic buildup of conjugated bilirubin? Or E, it's caused by a toxic buildup of unconjugated bilirubin? I'll give you a few moments to think of your answer. Okay, let's see what you've put. Okay, so most of you went with E, a few of you going with D, and a few of you going with C. Right, so moving on to the answer, it is E. So just briefly touching on all these possible answers. A, treatment's not required unless seizures develop. That's incorrect. If you think that the child has developed acute bilirubin encephalopathy, whether or not there's seizures there, you would obviously try and treat it. B, it's less common in neonates than adults. That's incorrect. It's actually more common in neonates than adults. That's because in neonates, particularly under 3 months, the blood-brain barrier is incompletely developed, and therefore there's higher risk of bilirubin crossing the blood-brain barrier. C, it's irreversible. That's incorrect. Acute bilirubin encephalopathy is reversible. What's irreversible is a condition called kernicterus, which is the kind of consequence of not treating acute bilirubin encephalopathy, which we'll talk about a bit on the next slide. And then D and E, it's a toss-up, isn't it? Is it conjugated or is it unconjugated? Well, if you remember, going back to that slide where we talked about bilirubin metabolism, I emphasised the fact that unconjugated bilirubin is lipid soluble. Therefore, unconjugated bilirubin can cross plasma membranes. And in newborn babies where they don't have a fully developed blood-brain barrier, unconjugated bilirubin can cross into the brain. So, just one final slide to talk about the complications of jaundice. So basically what we don't want to happen. So all of our treatment that we give is to prevent the baby from developing acute bilirubin encephalopathy and eventually kernicterus. So this is caused by a toxic buildup of unconjugated bilirubin in the brain, leading to irreversible damage and or death. It's more common in neonates due to high levels of bilirubin and an immature blood-brain barrier, as I mentioned. It's also more common in low and middle income countries, presumably because of the antenatal care given there. It's known as acute bilirubin encephalopathy acutely, obviously, hence the name. However, it can progress to something called connecterous spectrum disorder or chronic bilirubin encephalopathy. You'll probably hear it termed connecterous. Interestingly, connecterous, I think it was first described by like a German guy at the end of the 19th century. And essentially what connecterous translates to is yellow, icterus meaning yellow, and kern means like nucleus. So basically when they first discovered it, they discovered it on autopsy, and the nucleus refers to the parts of the brain where you see it. So essentially they did slices of the brain and found these like yellow stained parts. And essentially connecterous is the kind of unreversible, permanent outcome of developing an acute bilirubin encephalopathy that's not been treated or reversed. So signs and symptoms of ABE include lethargy, decreased feeding, abnormal tone, hypo or hypertonia, fever, seizures, and this thing called opisthotonus, which is basically when you get kind of severe hyperextension and spasticity, which leads to a sort of arching of the neck, head and spine. So it can be fatal, and it accounts for up to 15% of neonatal deaths in low and middle income countries. As I've said many times, connecterous is irreversible, and it can lead to a broad spectrum of neurological conditions like cerebral palsy, cognitive impairment, or it could lead to death if it's severe enough. Okay, so